This is the Advanced Brain Podcast with third-generation neurotechnology pioneer, entrepreneur, best-selling author, music producer, keynote and TEDx speaker, Alex Doman. Improve your mental wellness as Alex sits down with the leading thought leaders of our time about how to optimize your brain, body, and life with the latest and most powerful tools to help you reach your unlimited potential. This episode was previously recorded and released as part of the Sound Brain Fitness series and is being re-released here in the Advanced Brain Podcast. Now, listen in and discover how to become the best version of yourself with Alex Doman.
Good evening. I'm your host, Alex Doman, calling from Advanced Brain Technologies in Ogden, Utah. You can learn more about our vision to change lives by advancing people's brains at advancedbrain.com. We had some really intriguing questions submitted for my guest, and we'll do our best to answer those over the course of the next hour. Tonight's topic is neuroscience, personalized medicine, and faith. Neuroscience provides amazing insights into the complex biology of the human brain. But can it do more? Is neuroscience also a gateway to inner being? And can there be common ground between neuroscience and faith that are not mutually exclusive? Both science and religion seek truth and meaning, and my guest postulates that science plus faith equals consciousness. Tonight, my guest, neurologist and author Jay Lombard, together with me, will explore his fascinating career, how personalized medicine is improving lives, and the intersection of neuroscience and faith. So now let me tell you a bit about my guest. Dr. Jay Lombard is the co-founder and chief scientific officer and medical director at Genomind. He's responsible for Genomind's scientific research and development, as well as medical leadership and clinical oversight. Genomind is a personalized medicine company comprised of innovative researchers and expert leaders in psychiatry and neurology. Dr. Lombard is a board-certified neurologist and has published several books on the role of nutrition in the brain and has lectured extensively on the topic. He has had numerous television and radio appearances, including appearances on Larry King, Dr. Oz, CBS News, Fox News, The Early Morning Show, among others. He is also was invited to present at TED Med in 2012. He is currently a professor of neurology at Touro College of Osteopathic Medicine, and prior to founding Genomind, Dr. Lombard served as the chief of neurology at Bronx, Lebanon Hospital, where he led the stroke unit. He is also former clinical assistant professor of neurology at New York Presbyterian Hospital, clinical instructor of neurology and medicine at Albert Einstein College of Medicine, and chief of neurology at Westchester Square Medical Center and the Brain Behavior Center. Dr. Lombard is a graduate of Nova Southeastern University College of Osteopathic Medicine. He combined his psychiatry and neurology residency training at Long Island Jewish Medical Center in New York. Welcome, Jay.
Thank you very much, Alex. It's really a pleasure to be with you tonight.
I'm so pleased to have you join us this evening for the Listening Program Radio. And, I'd like just to jump in on a personal note. Can you share what called you to choose medicine and more specifically neurology for your vocation?
I think that the idea of choosing medicine to me, looking back, it's been so long right now, was sort of, almost a religious calling, if you will. I mean, I really believe that the, idea of healing people with, very serious conditions, as my practice was focused on, very serious types of disorders related to the brain, that was, a process that was in my way of being the best spiritual person I could be. I couldn't find a better career that would really exemplify, that type of giving or serving people other than in medicine. So that was kind of, sort of my call to the career. And as far as neurology goes, I started out as a psychiatrist and decided that I really wanted to have a more quantitative approach to the brain than psychiatry had at the time. and still does to some extent. I think it's gotten better, but I still don't think that neuroscience overall has translated very well into clinical psychiatry. So then I switched over from psychiatry to neurology, and then I realized, although I got a lot of information about the brain, how to read CAT scans and MRI scans, how to diagnose patients with every imaginable neurological problem under the sun, that neurologists really kind of were dissuaded from treating patients with primary behavioral issues, that they felt that if a person had an issue that they couldn't find an anatomical reason for, then they would just transfer the patient to a psychiatrist and say, look, this is not there's no physical cause for this problem. And I just felt very frustrated that sort of being in between two fields, if you will, where people weren't addressing these problems the way I felt that they should.
Well, I think it's interesting. It's a bit of a parallel. We met back in November when we were doing that panel at the Met in New York, and our moderator, Dr. Doring, also started his career in psychiatry and went to neurology, where he's now a neurology resident. And there are others, I'm sure, that have followed that path. So I'm curious, early in your career, you must have had some notion of the role of physician. And I'm curious how your perspective of that has changed over the years. Is it different?
I think that, there are clearly more people who are gravitating towards this area of this no man's land, if you will, between psychiatry and neurology. I think that there's a growing field. There are now, specialists called behavioral neurologists or neuropsychiatrists that are focused on the intersection of psychiatry and neurology. When I trained, which was 25 years ago, that was you chose one or the other. And although that the American board gives us our certification both to psychiatry and neurology, and we have to rotate through each specialty, I think that there's a real sense that behavior is not a biologically driven process, and that's frustrating to me because clearly, our cognition and our behavior and our faith and all of the issues that are, the higher cortical functions of the brain, if you will, are very much underlie those types of processes. We need to understand how that actually happens. And I think we can have deeper faith when we explore the biology of these types of, the origins of these types of concepts.
Now, you co-founded a company called Genomind, where you're chief scientific officer and medical director. And my understanding is that this is a personalized medicine company. Can you describe what it is that you all are doing over there?
Sure. So we look at, a genetic assessment of patients with psychiatric conditions, especially patients who have failed medication trials. Usually, unfortunately, if a person goes to a psychiatrist with a medical problem or a psychiatric problem, it's really trial and error. It's this medication, that doesn't work, try this medication, that doesn't work, switch to this medication. That is the norm, not the exception in psychiatry. And our goal is to really put some science behind that so that when doctors are choosing medication, that they have more data to make those decision processes as opposed to just arbitrarily deciding on one medication or another.
Well, and I think it's interesting that you describe this as an arbitrary process, and I think that's why we see such a trend towards an interest in functional and nutritional medicine, where the error downside isn't potential risk of death if we get the medication wrong. So I'm interested to have a better understanding about what personalized medicine really is. So you've got a patient, for example, with a diagnosis of schizophrenia, and you do some genetic testing, what is that testing telling the psychiatrist when it comes to recommending a pharmacological intervention?
Let me back up first and bring up a point that you made, which I think is a very important point, which is ultimately the goal of the pursuit of companies like Genemind, and quite frankly, hopefully there are others that are trying to do the same thing. Is not to just get medications right. I mean, that's certainly part of the process for mainstream psychiatry, to take our existing tools and make them work better by understanding how genetic variants can influence medication response. But more important than that, and that's the point you exactly just raised, is will this, sort of endeavor of understanding genetics help us to really clarify and elucidate what are the underlying biological factors involved in conditions like schizophrenia or autism. And that really is what's most compelling and most interesting about what we do. I think we have some clues, very good clues actually, about some of those causes.
So, specifically, how can these genetic and biological markers inform psychiatric treatment? I know that you personally have identified some of these, markers. So in terms of what does the process look like? Physician orders a test kit. Is that correct? A genetic test kit, and then information comes back from your lab. And are there specific recommendations for treatment? How is the physician interpreting your reports? I know there are a lot of questions in there, but really, what's the mechanism, the process involved?
The process is very simple. Really, the doctor explains to the patient, about the test. And we collect a small saliva sample. You literally spit into a test tube that's sent to our lab, and we analyze the genes that are important to those decision-making processes. And those genes are divided into two categories. One is related to drug metabolism, because most psychiatric drugs are metabolized by enzymes that exist in the liver, and people metabolize drugs in different ways, so that you take a certain dose of a drug, two people can have very different reactions to the same drug in the same dose because their metabolism is so different. And a lot of patients have significant side effects with psychiatric medication because of those variations in the genes that regulate those enzymes. The second and more interesting area of our test relates to things like neurotransmitters. Neurotransmitters are signals in the brain, things like serotonin, dopamine, and glutamate, which are very important neurotransmitters for mood, for things like anxiety, for sleep. All of the the biological processes that regulate behavior are frequently disrupted in some way in major psychiatric illnesses, and there are genetic equivalents to those pathways that we can identify and help the physician to understand them, so that either medication choices could be changed, or in a lot of scenarios, instead of medications at all, using nutraceuticals or non-pharmacological agents that can sometimes be as effective as any medication available.
Well, certainly, and I'm interested. One area I know neurologists really struggle with is with anticonvulsants for individuals with epilepsy. Have there been any advancements in this form of testing to better select anticonvulsant medication for these patients?
That is a phenomenal question, and the reality is that those of your listeners that are interested in this in a deeper way, I'm going to give a gene that is so fascinating that I think is a way of answering this question. And the gene is called a calcium channel gene, and the abbreviation for it is CACNA1C. You don't have to really remember that unless you want to look it up on a medical site, but the calcium channel gene is vitally important in the biology of psychiatric illnesses for several reasons. One, it's been discovered that despite what your psychiatric diagnosis is, that gene appears to be more frequently abnormal than in other types of conditions. So, for instance, it shows up more frequently in bipolar patients, in patients with schizophrenia, autism, and other conditions as well. And the question is why? Why is that one particular gene so much more frequently seen in these conditions? And that's what we're beginning to understand, sort of what the underlying mechanisms of that are. And it leads us back to why anticonvulsants are so effective in certain patients, not only with bipolar, but in many conditions in which the level of excitement of the brain, which is controlled by these calcium channels, becomes dysregulated in certain ways.
That's absolutely fascinating, and I'm curious what patients is this personalized medicine approach most useful for today?
Well, I think that people obviously are curious. My wife and kids want to get tested, and I discourage people from doing this out of curiosity. I mean, this is a very complicated field. We're still making headway in what we understand about it. I think that the clinical utility of a test like this are really for individuals who, are frustrated by sort of the treatment as usual, where they've seen a psychiatrist or a primary care doctor, they've taken a medication, they've had adverse effects, or that they're not getting relief of their symptoms, and that they just don't know where to turn next. People, and unfortunately, this is a large percentage of the psychiatric population experiences this, and this is the norm, not the exception, where a large percentage of patients with serious psychiatric problems don't really experience relief, no matter what medication the doctor tries. And this is really where we feel the opportunity for this technology is most important for people to actually seek out.
Well, and there's some controversy too. I remember when my wife was pregnant with our youngest son at a certain stage in her pregnancy. I don't remember how far along. Our physician, said that he was obligated to inform us of the availability of a genetic test that would see if there was a predisposition for our child to have Down syndrome. And with the notion that we could make a choice to continue with or abort the pregnancy if in fact that came back. And simultaneously, he told us that he was a research site for this testing, and he had an overwhelming number of false positives come back, which potentially, would lead some parents to make a very difficult, misinformed decision. So, I do think this future of genetic testing is like a double-barreled shotgun. There are some potential downsides, and I just wonder if you have any thoughts or experience with that.
Yeah, let me dispel some anxiety about this, though, because I think that there is a very significant misnotion about genetics as it relates to psychiatry. So, for instance, there are genetic disorders that, if you have a gene, you will develop that condition. Sickle cell anemia, for instance, or, there's several, cystic fibrosis where, these are genetically entirely genetically based disorders. They're really binary. If you have the gene, the gene will be expressed, and you will have that disease. We are nowhere, and nor will we ever be there in a deterministic way in psychiatry. And the reason for that is that genes related to psychiatric illnesses are probabilistic. They're never deterministic, meaning that they may increase the probability or decrease the probability either of a condition or a response to medication. But there are so many other factors that are involved in that, environment and just a host of other factors that it's very important for people to understand that having a gene, for instance, that may be a risk factor for a particular condition does not in any way mean that that person has that condition or will ever develop that condition. And the second point in terms of genes in psychiatry is that it's never, a monogenic disorder, meaning that it's one gene that's going to produce a condition. There are literally hundreds of genes that are probably involved in the expression of these conditions. And we're not about diagnosis. Our company is not looking to make diagnoses based upon genetic testing because we don't believe that those diagnoses mean anything other than just a label or a description of behavior. What the test does is shows what biological factors, which are genetically based, can actually affect or influence medication metabolism. And to a lesser extent, although certainly I think important as well, are what are the biological factors that can, increase one's risk of depression for a variety of, various, mechanistic reasons, but never deterministic.
Well, and there's, and I'm really, it's so refreshing to hear a neurologist discuss labels the way that you did, because we're in agreement. Description of some symptoms that an individual has, and I know that a lot of autism research right now is going toward genetic testing in children. Do you have any opinion on that?
Well, I think that there clearly are genes that are related to an increased risk of autism. In fact, some of the same genes that are increasing the risk of autism are also related to increased risk of other psychiatric conditions as well. And we know from family history that that's also, true. That this is, and all that really tells us is two things. One, that these conditions are biological. There's nothing that parents are doing wrong necessarily that produces a child with autism. And two, the real opportunity here through this type of research is to understand the fundamental mechanisms that are causing the brain to produce a condition such as what we call autism. And that to me is where neuroscientists are most focused on, is really trying to understand, how do you get from a gene abnormality to a behavior like autism or schizophrenia? How do you trace that pathway all the way from the identification of that gene to something as complex as behavior? And that is the opportunity there, is we will be able to transcend our symptomatic treatments as we have right now for conditions like autism and schizophrenia, and transcend that in a way that we're addressing the underlying biological mechanisms so that we're really treating these conditions specifically as opposed to just symptomatically.
So do you envision a future where genetic testing becomes a standard course of medical care in psychiatry?
Oh, yeah. I think that not only in psychiatry, I think in all of medicine, but I think there's a very, steep education slope, both for physicians as well as individuals and consumers and patients. Again, I want to just reiterate that, that deterministic issue, that genes are, in psychiatry, are probabilistic. We'll never find a single smoking gun gene that says you have this gene, therefore you have this diagnosis. It will never happen. And that's, I think, a good thing, because we need to understand that, psychiatric diseases are really a nature meets nurture issue, where there are biological factors which increase one's vulnerability based upon how we respond to, stress, whether it's physical stress or emotional stress or both. But it's really the 1-2 combination of that genetic or biological vulnerability that meets the environmental experience that actually triggers the expression of a mental illness. So we can't take one without the other. And, it really is a nature plus nurture issue.
And is it true that the majority of psychiatric conditions are disorders of white matter connectivity?
Well, that's kind of what my book is about. That's a big question. I think you have to kind of step back and sort of explain what actually that means. So, if you look at the gross anatomy of the brain, we have gray matter and white matter, and traditionally, neurologists and psychiatrists have looked at the gray matter, the neurons, to detect, where if there's some anatomical location in the brain, where we'd find it in the gray matter. The white matter is really the areas that are responsible for communication between brain regions, and also communication between self and other, the outside person or the universe at large. That's really a white matter function. And what we've learned through, various types of, neuroimaging studies where we can assess the integrity of white matter in ways that we never could before, we are seeing exactly what you just said, that it appears that the evidence as it comes in, because obviously this is an iterative process in terms of research, but that the majority of psychiatric conditions are in fact connected, if you will, no pun intended, to disconnection in some way. And if we think about, what do we mean when we say a person has a psychiatric disorder? What we're really describing is that there is some disconnection, whether it's between themselves and their family, between themselves and their community, between themselves and themselves. Anatomically, that is, parallel to how the brain, functions through these white matter, connectivity paths. So I think that statement that you just said is accurate, but I think we need to explain a little bit about what that actually means. But the answer, long-winded, is yes. I think that is true.
So I think that's extremely helpful, and maybe going a little further along this path. If we see a disorder more associated with gray matter, if you will, as opposed to white matter, what are the treatment implications? Same type of course of treatment, or do we have to look at it differently from a treatment perspective?
So I think that one of the disappointments I have personally with your listeners may be aware about the Human Connectome project, which is about looking at MRI scans and really mapping out all of the connectivity within the brain by literally hundreds of thousands of data points in both normal and abnormal brains to see where this disconnectivity actually specifically is. What circuits are malfunctioning, but unfortunately, there's not a lot of emphasis in what's called translational neuroscience, taking that information and really helping to apply it to make actionable decisions, if you will, or clinical trials on agents that may restore connectivity in certain ways. Probably the most advanced interventions that we have to date that actually do attempt to, base our interventions in patients that have disorders of connectivity are non-pharmacological. Things like magnetic stimulation, also called TMS, a lot of the types of technologies that you yourself work with, including music and various somatic therapies, meaning body therapies, are more likely to improve connectivity than any kind of specific biological agent. That we really haven't found a lot of those types of things that improve white matter conductivity, if you will. How do you help improve those circuits with a drug? We don't have those types of solutions.
So you've talked about some of these other non-pharmacological interventions. What about nutrition? How vital is that to restoring the connections and maintaining?
I think another opportunity for genetics, obviously, is if you're able to predict with a greater degree of certainty about a person's risk for developing a condition like autism, that the time, or schizophrenia, that the time for intervention is earlier rather than later. Because by the time, let's say, a child develops overt schizophrenic symptoms, they may be in their late teens, but we know that anatomically the adverse pathological effects are occurring much earlier on in the disease before there may be any overt clinical symptoms. So, the idea is to catch those conditions before they're fully expressed. And that's where I think nutrition is going to play an increasing role, where we can actually understand the specifics of what nutritional factors are involved. So let me give you just a couple of pragmatic examples. There's research that's been done at Baylor that looked at mitochondrial dysfunction in autism, and particularly in male children with autism, that a significant percentage of these children had an inability to metabolize a amino acid called carnitine, which is required for mitochondrial function. Carnitine improves the sort of energetic biology of mitochondria in cells, including the brain. The advantage of actually genetically testing those types of children is obvious, that you can actually bypass the carnitine deficiency and load them up with higher doses of carnitine so that their body can utilize this amino acid to help the developing brain. There's other examples like the case of methylfolic acid, which is a folic acid-like product that's been associated with certain percentage of patients with depression, in which people have genes that prevent them from adequately making this type of folic acid. And knowing that allows us to restore normal folic acid through a medical food or nutritional intervention as opposed to a drug.
And what you're touching on also then relates to obviously the dietary choices that are being made, and families that subscribe to biomedical interventions for autism. Often one of the first lines of attack are gluten, casein-free diets. Do you have any comment on that?
Yes, I do have a comment on that. I mean, when I first had heard that back when I was in practice, I heard that anecdotally from lots of families, and lots of people sort of empirically, place their children on a gluten-free diet, and sometimes parents felt that it made a big difference, and sometimes it didn't, and kind of we scratched our heads and said, well, we don't really understand, why certain people, get improvement and others don't. And, we would send them for, basically for a celiac test, and it would come back normal. And then we'd say, well, there's nothing to this. Go ahead and go back and eat wheat. And then, flash forward a couple of years, and I had the opportunity to make the acquaintance of a really top-notch researcher at Columbia, whose name is Armin Aladini, that is a real, very big celiac disease expert at Columbia, and has done, very, very rigorous research on the fact that a significant percentage of autistic children and first-break schizophrenics have, in fact, antibodies to wheat, not the celiac portion of the wheat protein, but other non-tested elements of the wheat protein that induces an immunological response that's not seen in people who are not affected. And that, to me, is a big, big deal, because I envision this, if he can validate this on a larger scale, which I know he's trying to do right now, that at some point I think we're going to be, checking children at a much younger age, like we do for a condition called PKU, in which if someone has an enzyme that's lacking called phenylalanine, that if they don't put phenylalanine in their diet, they don't develop seizures or mental retardation. And I foresee that this will happen, hopefully sooner than later, where we'll be checking children who may have this type of immune reaction to wheat, and put them on a very strict gluten-free diet. But that's not for everybody. I think we have to have more specificity on who to recommend that to.
And that's the kind of research and work that you're doing is, getting us closer to that. It's not one size fits all, and I guess that's the general idea of personalized medicine is the whole. Just pragmatically, Jay, how does one find a physician that practices personalized medicine? Is there an association? Is there a directory? How do they go about that?
That's a great question. There is something called the Coalition for Personalized Medicine, which is a DC-based group that, probably provides a lot of sort of, groundwork support. I think each specialty has their own sort of growing body of people interested in this, but not in a formal way. For instance, if people are interested in this, they can, visit our company's website or, speak to, someone at our company to find a doctor in their neighborhood or at least in their city that's familiar enough with this, because right now, it really is, taking off as a concept. But I would say still 2 out of 3 doctors may look at you funny when you ask about, I want a personalized medicine evaluation for my wife with depression. I was like, okay, what exactly are you talking about? So I don't think we're there as a mainstream, state of art, if you will. But I think that will happen soon. And, with enough people demanding this from their doctors and realizing that the data does support better clinical outcomes than just treatment as usual, where we're empirically throwing medication at people.
Do you see any resistance in the medical community to this type of approach?
Oh, sure. Are you kidding?
What's standing in the way from making this the norm?
Well, I think that, the funny thing I always hear is there's not enough data. So I think people who say that there's not enough data don't know what data actually means, because, the genes that, are that we currently test for have been validated in thousands of patients, literally thousands of patients. But I think, that perhaps a valid criticism is that, well, you don't have prospective trials, meaning that can you show us, and this is what the skeptics say, and I think this is a fair counterbalance question, is can you show us prospectively that having genetic data in a clinical setting like a psychiatrist's office will improve outcomes in a way that's better than not having that data?
Right.
I think that it's obvious that it will, but we don't have that kind of data. We actually have some, signal that that's true. But I think that to prove people beyond a shadow of doubt that you have to show, a certain level of evidence that notion is indeed true. And I think we'll get there, but that's kind of the resistance that people have, especially insurance companies, that say, look, we're not going to pay for this unless you show us data. Well, okay, we'll show you data, but how much data do you need? I mean, is 1,000 patients enough? Is it 3,000 patients? What exactly is that number? So we don't feel like as a company that we're kind of like, a Peanuts comic with Charlie Brown and, the football keeps getting picked up by Lucy. So I think sometimes, being in a startup company like this, it sort of feels that way.
Well, and I guess we have to consider who's going to be motivated to fund, what are very large-scale, multi-million-dollar randomized controlled trials.
Right.
Where do you tap into that kind of funding? Are the big pharma companies going to be motivated for this kind of research to happen?
Not at all.
Right.
because they want the one size fits all. They want their antidepressant to be for everybody. They hate the idea that their antidepressant's only going to work in 30% of the population and not the other 70%, and that somebody else is going to come along and say, well, our antidepressant works in the other 40%. Well, that means decreased market share for them. So you're right. Waiting for them to fund these kinds of studies is never going to happen.
Right. So, we started to touch on your book a little bit, and I'd like to, maybe switch gears now and move on to that topic. You do have a new book coming out on the topic of neuroscience and faith. What can you tell us about that?
I can tell you that the editor just looked at the first our first draft and told us to go back to the starting.
Well, that's
but
that's always the first step after the initial draft of the manuscript. Completely restructure this.
I guess that's true. Maybe I was expecting too much, but it's a very complicated topic, obviously. And
Certainly.
I think a good anecdote is that my daughter last night, when I was tucking her in, she said, "Dad," she goes, "how do you know that God exists? And is it possible it's our minds that create God to comfort us, but it's just we're making up that idea of God?" And I said, "Wow, that's exactly what my book's about, Julia." So that exact question. So hopefully my editor will understand sort of the sophistication of a 12-year-old that asks those kinds of questions. And and I think if people want to say, well, what are you doing in a biotech company that's looking at genetics and psychiatry and writing books on neuroscience and faith? These things have nothing to do with each other. Which, by the way, I ask myself on a daily basis that exact question. And I think the best answer I can come up with for myself is that I really am driven to make the invisible visible. How do we actually take something that we can't see, we can't quantify, and really help to show at least the contours of something so that we know that it's real. So a psychiatric problem we know is biological. There's no question in my mind that majority of psychiatric conditions are, at least in part biologically driven. And, our biomarkers, whether it's genetics or other biomarkers, gives us the contours that allow us to make that sort of affirmation. And I think the same thing is true with faith. I think that, we have to show people the reality. We can never prove faith. We can never prove that God exists. We can show enough evidence that, look, it's impossible for a person, any rational person, to look at the evidence and to conclude otherwise. And that really is the goal of the book.
Well, it's a lofty goal. So, as we talk about faith, Jay, what's your concept of God?
Well, I think that my concept of God is that we can't have a concept of God because God's beyond the concept, number one, and that's what makes the idea of writing a book about the concept of God, sort of a masochistic enterprise, if you will. But I think that if we had to summarize, at least in my opinion, about what faith is that we actualize God. We actually, through our actions, through our life, through our doing good in our life, we actualize God. And what I mean by actualizing God is that we make God visible through our own lives. And we do that through our connection with each other. And that's what, my belief that is what God commands us to do, is to love each other in such a way that we are acting as God's liaison in our relationships with each other.
Well, and you touched on something earlier that I bring back in discussing the white matter, and that white matter is kind of how we connect to the world beyond ourselves. And this discussion is going to this, collective consciousness idea. We individually, if we hold an image of God in our mind, we do so, but as societies and followers of specific faiths, we share this construct of what God is and how God manifests within our life. And I just find that fascinating, right? Because we hold this individual idea, but it is interconnected with so many hundreds of millions of other minds that maybe share that same idea.
Yes. And I think
what is it?
Yeah.
What is that connection? What is that network that allows that to happen?
Well, I find it ironic that the word religion itself means coming together or to believe something together or to know something together. And yet we find that, unfortunately, religion divides us as opposed to unites us. So we say, oh, your ideology of God, your concept of God is different than my concept of God, and therefore, we're going to go to war and bang each other over the head because our concepts are different. So, for me, the challenge is, can we write a book using neuroscience as an anchor to have faith without an ideology? So we don't have to say that my concept of God is any different than your concept of God, and therefore your concept is invalid because mine is valid. I think that, there's a great quote by a philosopher that I think was something to the effect that, God doesn't want us to argue about him or it. God wants us to, actualize through our relationship with each other. And that goes back to the connectivity issue, and and that is a tie-in that we talk about in the book, about the obviousness of disease, whether it's psychological disease or spiritual disease, being a disconnection, some level of disconnection. And the opposite of that, health, whether it's brain health or spiritual health, is the idea of connectivity, of attachment, of cohesion, and integration. And if we just kind of think about those concepts and really kind of reflect back on our own lives and see where, our own lives have gone wrong when we've been disconnected from our true self or from our relationships with people that are most important to us. Or conversely, when we're really, honed in on ourselves and our loved ones and our faith, that things really work well, So I think that's a very simple notion, but hard to execute, obviously, right? It's easy to talk about, hard to do.
I think we all have our individual struggles with that, and I'm interested. Where is the common ground between neuroscience and faith? Where does that intersection happen?
Yeah, I think that I think it happens in I think there are certain areas of the brain that are more aligned to faith than others. I think that if you look at sort of our brains as being binary, and the left hemisphere of our brain, which is pretty much dominant in 99% of the population, we use our left hemisphere of our brain, especially if we're right-handed, that's a very linear, objective, measure, quantifiable sort of element of our brain function. And the right hemisphere of the brain is much more about this, this white matter connectivity, integration, seeing the whole, the gestalt, if you will. And we know that from imaging studies and other types of, ways of looking at people in deep prayer or meditation, that there's increased activation of the right brain and reduced activation of the left brain. So I think that if you ask where the intersection of neuroscience and faith is most evident, it's in our right hemisphere of our brains.
So we're seeing through functional imaging insights into the actual biology of belief. Then.
Sure. Yep. I mean, it doesn't tell us that
there's a faith neural network.
That's right. It doesn't tell us that the belief is true. It tells us just that the brain is operating in a faith-based way when you see activation of those areas of the brain. So it doesn't really tell us that the person who's in that state is actually communicating with a higher power. That we're not going to get there from imaging. We're not going to be able to prove that God exists through imaging the brain. What we do prove is that there are different areas of the brain that are activated during faith-based experiences, which are quiescent when we're busy finding words to describe things, and as opposed to the ineffable, which is what those experiences usually offer people that have them.
So there's been research that's shown that meditation practice can, in fact, change functional structure of the brain, which would then, have me suppose, and perhaps incorrectly, that our focus, our consciousness, our contemplative practices can help us to structure the brain in such a way, or to help shape it or influence it, so that we have a better opportunity for belief. And maybe going further than that, can our faith in belief, in fact, help our inner connections that are broken in some of these psychiatric conditions?
Yes, I think that's. And I think that it's unfortunate that as medicine moves to a more, quote unquote, evidence-based and objectifying and quantitatively measuring things, that we lose the essence of that effect. The old-time doctors were sort of, an old world kind of person that I remember, training with doctors who were very good at placebo effects and sort of the intangibles of medicine that really made a difference. And we kind of stripped those away and just, want to measure everything. And I think that we're losing a lot of the art of medicine in that process, which to the detriment of people who need those non drug-based or surgical approaches to their conditions, like psychiatry. A great therapist would develop a relationship with a patient that allowed that patient to have sort of a surrogate parent, and allow them through that relationship to develop, better coping skills than they had before they saw a therapist. And unfortunately, I think that's a dying art.
Yet there are medical institutions, as you speak to the art. Cleveland Clinic comes to mind, that is very progressive, and the incorporation of art into medical practice to help the patient condition. From healing to palliative care. So I think there are pockets, where we're seeing this, increased use of music therapy in medical institutions and of art therapy and live music performance. So, I see hope in the arts, and then hopefully we're not getting too evidence-based, and that we allow some more of the intangible.
It's thanks to people like you that are doing that kind of work, because you're keeping sort of that aspect of medicine, which is very important, right? So in traditional healing, whether it was the shaman or drums or, certain kinds of body movements, whatever that was, that's something that was so effective in traditional healing practices that, it's really gratifying to know, and I really appreciate everything that you're doing and, the work that you've done with, looking at the effects of music and sound in the brain, because it's such a fundamental aspect that is so overlooked in our conventional, practices.
Well, I'm curious, and we spoke about this in November when we were all sharing that table in that wonderful room. But what role do you see music as playing in healing the brain in our psyche?
Oh, I think it is fundamental, especially music without words, because words then take you back into your left brain. But music without words is clearly a right brain activated process, and so much of that connectivity and that healing can take place through the medium of music in ways that you could just never get to in other types of modalities. So when I was in practice, I saw a lot of the Tomatis method, I guess it was called, and some other technologies that were really, really effective to help balance these children. And it's just, I think we need to train our up and coming neuroscientists to pay more attention to understand exactly what's happening, so that conventional medicine has a better respect for these types of non-traditional modalities.
Well, it's wonderful, and my 20 years that I've, been in the field, I have seen such a change we all have in music effects research and neuroscientists taking an interest in studying the effects of music and identifying those mechanisms and what type of music can elicit what kind of changes in specific brain regions. But I still think we're in our infancy, and it will be my lifetime before we really see this realize a point in which it may become a standard practice of care, much like the personalized medicine that you're advocating for. As we're in our closing minutes, I want to go back to a larger concept, and I'm very curious, Jay, to know how you define consciousness.
For the last 5 minutes, I think that consciousness.
The Cliff Notes version, right?
I think it's very much in my mind similar to that definition of religion that we talked about, which is knowing something together. There's a wonderful book. It's probably out of print, but there was a very spiritually inclined evolutionary biologist, believe it or not, named John Acclaimed, who won the Nobel Prize for his discoveries on brain development. And he said that the ultimate goal of the evolution of the brain was to have consciousness and to be aware of the fact that this is not by chance, and that that life has meaning, it has significance, it has purpose. And that is, the highest sort of, ladder that the human being could climb, is that awareness. So I guess I would want to, echo that sentiment that he had about the purpose of consciousness is to know something, and not just anything, but to know something together. And that togetherness is that, is our connectivity to each other, and to the world at large, and that we all matter to each other in ways that are really incomprehensible but very tangible. We may not be able to really assess them or know their effects, but the effects are very, very real, and we can see them now in things like brain imaging, where we can see the effects of faith or the opposite of faith in psychiatric diseases, and really understand how profound the damaging effects are to disconnectivity in children's brains or in other people. And hopefully that gives us a greater level of accountability, a greater level of moral responsibility, and a greater sense of just accountability for our lives. And I think that, is a long-winded answer, because I think, consciousness becomes sort of a philosophical issue as opposed to a very real, pragmatic one. And I think we need to move away the definition of consciousness from something theoretical to something that truly is tangible, and means something. It really does mean something.
I think that's a perfect end note. Jay, thank you. This and can you tell us, is there a title for the book yet that we can be looking for? And
sure.
An anticipated street date and publisher?
Yeah. So it's by Random House, and the working title of the book is Mind of God. Subtitle is we're still working on that, but it's probably going to be called Brain Science and Faith. And it's due out, hopefully, if the second version the editor likes, maybe a year from now, hopefully, God willing, as they say.
God willing. Well, I'm personally looking very forward to reading that, and I want to thank you and our audience. This concludes tonight's program. To learn more about Dr. Lombard and his pioneering work at Genomind, visit Genomind. That's GENOMIND. mind.com. For more information on the listening program and advanced brain technologies, visit advancedbrain.com or just give us a call, area code 801-622-5676. Thank you all for listening. Once again, thank you, Jay, for taking this hour with us. It was very insightful and enjoyable.
Thank you.
Okay. Thank you. Be well, everyone.
Thank you for listening to the Advanced Brain Podcast with best-selling author, keynote speaker, and founder of Advanced Brain Technologies, Alex Doman. In the show notes, you can find links to all the resources mentioned in this episode. Please subscribe to the podcast from whichever platform you might be listening in. Of course, it's free to subscribe, and it ensures that every time we post a new episode, you'll find it right there waiting for you to listen to in your podcast app of choice. And for more information regarding the world's most innovative neuroscience-based music programs for optimal human performance, please visit advancedbrain.com.